Ravi, as you know, there's been a lot of emphasis in guideline changes over the past few years, really, from the European Society of Cardiology through to NICE, with an increased emphasis on management within primary care after revascularization has been considered within the hospital setting. And also we have a much greater range of drugs that are available for the management of stable angina. From your perspective, have you noticed these changes, and have you had any difficulties with ongoing management of these patients?
The question you put, we do, as we see these patients, we consider angina as a possible cause. Often it's obvious it is angina, we refer them on for confirmation and consideration of revascularization or CABG as appropriate. And we leave initial management, obviously immediate management, we start off with preventive therapy. Hopefully they're already on that by the time they see you. But in terms of when they come back to us after revascularization or further investigations, I think we are seeing some changes in current management. But it'd be interesting to see, whether this trend is sort of widespread. It'd be useful to see the effect of that as well.
Yes, I mean, I think you're right. I think the role of revascularization for stable angina has been looked at, and we know that there are groups of patients that benefit prognostically, but we know that there are large numbers of patients with anatomical coronary disease who can be as well treated with medical therapy. Also, of course, as we have an increasing aging population, we have a larger number of people with more complex medical problems for whom revascularization may carry a significant risk. So again, we're left with options with medical therapy. I think from our perspective, the drugs which we know have prognostic impact are statins and ACE inhibitors, and that's always my first priority. And then of course we have a range of drugs that we can offer patients once we've looked at whether revascularization is in the patient's best interest. And of course patient choice is very important in terms of whether they want to proceed with revascularization and the mode. And we of course use anatomical information with functional information, stress echo, perfusion scanning. Most of that will be done within the hospital setting. And then once we've settled with the patient on a strategy plan, we send them back to yourself.
Sure.
Which drugs do you tend to use first line?
We will have hopefully considered all the preventive measures,
Yes.
Primary prevention, secondary prevention.
Absolutely, yeah.
As first line, and obviously for specific anti-anginals, beta blockers as long as there's no contraindications to those, and often calcium channel blockers.
Yes.
Either or both often.
Yes.
They're already on combined by the time they come to us sometimes, but if not, if they're presenting back to us frequent enough whilst they're waiting to see, we will, provided there are no contraindications, provided they're hemodynamically stable, we'll probably add in the other.
Very good, yes. I mean, and it's interesting, for nearly 20 years we had the same drugs, only those drugs. We had calcium blockers, we had beta blockers and oral nitrates, both effective, all of them effective. But of course, some are not tolerated by patients, and some of them need more drugs. We've now got some newer drugs on the market. We have other rate-lowering drugs, such as ibabradine, which require some degree of heart rate monitoring, but can be tolerated by some. And we have this new class of drug, Ranolazine, the late sodium inhibitor, which the data suggests is effective for angina, and NICE have positioned this as a second-line drug to consider once we've tried the conventional drugs. From your perspective, in terms of a new drug being required, what are your concerns or fears, and what are you looking for from the drug?
Interesting. Obviously, new drug, you obviously worry long-term safety, obviously efficacy. Probably won't be on the market if it's not efficacious, so you hope, but safety is the main concern, and monitoring. What monitoring am I required to do in primary care? Especially recently, we're getting increasing requests from our local unit, local trust, to provide Ranolazine. And yes, I mean, I've taken that on board, and then actually, even though it's not on their formulary as yet, but I've been promised that it will be, I have prescribed it on some of my patients, and I've seen good results in some of those In terms of my concerns, monitoring, when do I start?
Yes.
What do I look for once started?
Yes.
And long-term evidence, is it actually just a symptom relief, or has it got a endpoint data
Yes.
like ACE inhibitors do,
Yes.
like beta blockers do in
Yes.
heart failure, for example?
Yes. No, I think that's very important, because I think in terms of a new drug, there's always a slight apprehension to starting. I think the first thing that seems to be coming out very clearly is that it's effective at treating angina, both in terms of symptom relief, lower GTN consumption, and if you objectively evaluate patients on a treadmill, they can walk for further. So we know it's effective. I mean, certainly my advice is always to try the traditional drugs first, as per NICE guidance, but then this drug should be considered in the second line group. Its advantage, I think, from a primary care perspective, is that it doesn't require any specific monitoring in terms of blood tests or heart rate assessments, which I think is important, because I think practical follow-up of these patients is presumably not very easy from your side. No. And I think the other thing is there are very few drug interactions, very few serious side effects, if any. And I think that the other advantage is that it's hemodynamic neutral. It can be used in heart failure. A lot of patients with difficult to treat angina have heart failure, and it can be used with a neutral effect on the patient. It doesn't lower blood pressure, it doesn't cause a predisposition to worsening heart failure, and I think that's very important. So I think the lack of sort of objective monitoring is useful. I think the groups that I would always look out for, and it's worthwhile checking with the hospital, are patients who have significant liver disease and renal disease. I think they're patients that I think one has to have a degree of caution. And I think also, as with so many drugs we use, patients over 75 have a higher side effect profile. So I usually start very cautiously in that group at a smaller dose of 375 milligrams twice a day. Often I find in the elderly there is a balance between side effects and benefits, and I can be quite pleased to keep them on that dose if it relieves their symptoms. If they remain symptomatic after around 3 to 4 weeks, I will increase the dose to 500 milligrams twice a day. And I find that in the vast majority of those patients, that's the only dose we need. In younger patients, we can of course go higher to 750 milligrams. I think in the elderly, I would always start at a lower dose, and not feel obliged to increase unless their symptoms will dictate.
Just from my perspective,
Yes.
when I've started patients on Ranolazine, I've started several, and I haven't yet come across much in terms of side effects. But are there any particular? Obviously, I've been told that these are commoner in elderly age group. But is there anything specific I need to be concerned about, looking out for, worried about? What are the commoner ones that you see?
The good news about Ranolazine is that it is very well tolerated and has very few significant side effects. The main side effects to look out for and to warn patients about are gastrointestinal. They're usually quite minor: nausea, vomiting, constipation. Some people may also feel dizzy, and the important thing to let the patients know about is that these effects usually only last for the first 2 weeks, and certainly the clinical data would suggest drug withdrawal because of these side effects is very rare, particularly in the younger patients. In the over 75s, the side effect profile, as ever in this group, is slightly worse with gastrointestinal disturbance, but again, I usually find starting at a lower dose of 375 milligrams twice a day in this group, they can usually see through any minor side effects that they will have.
Right. Okay. Are there any particular drugs I should avoid? I mean, I think there's some listed contraindications, and many of these patients that we see in primary care often put them on antibiotics. And,
I think the first thing I always say to anyone in primary care, and indeed secondary care and tertiary care, is that whenever you have a new drug, I think it's always safe to check before you prescribe. But the advantage with Ranolazine, it's been used in combination with other anti-anginal drugs very safely, so we know it can be used in combination with those drugs. It can be used safely with ACE inhibitors and statins, the mainstay of treatment for stable angina. In terms of specific drugs, there's a small number of antiarrhythmics where you shouldn't use it, and the biggest group of drugs are the so-called class A, 1A drugs for arrhythmia treatment, quinidine. But this is relatively rare, and I would suggest, as a practical advice, if a patient is on a antiarrhythmic drug, it may be worthwhile just discussing with your local cardiologist, because there'll be such a small number. The other more common drugs within primary care are certain antibiotics, particularly erythromycin and clarithromycin, because of the way in which the drug works. It can interact with those drugs, so I would avoid in patients on these antibiotics. The reality is they'll only be on these antibiotics for a short duration anyway, and then you can stop and then start after that. And the other important group for primary care are antifungal drugs, particularly ketoconazole. So I think if you're on any of those drugs, I would finish your course before starting on ranolazine.
Right, presumably because of the CYP.
Yes, exactly.
Yeah. Right. Okay. Great to hear that.
Okay.
Thank you.
Thank you very much.